case you are seeing is a twins baby, and twins has a limitation that we have almost detect 20% of the less anomalies than that of the singleton. So that is one of the causes of not seeing the anomalies. I have not used the word missed anomalies, because missed, when you say missed, you actually commit that you have done something wrong. So in this talk, I will take you through in next 20-25 minutes to the late appearing anomalies, role of the third trimester scan, limitation of the mid trimester anomaly scan, and common anomalies of the medical legal issue, and then detection rates of the anomalies worldwide, and then the brief counseling. So I will start my presentation with this case, where the 32-weeker primary was referred for evaluation of moderate polyhydramnios. Mid-trimester anomaly scan and early anomaly scan showed no congenital anomalies. Dual marker was low risk with serum free beta HCG and Papa values were normal range. And walk-up for gestational diabetes, that is very common in our population, was also being done. So what I find that AFI was about 32 centimeter and deepest vertical pocket diameter was around 10. So that was definitely a moderate to severe kind of polyhydramnios. Then I further looked and I find that there are two bubbles and those bubbles were connecting to each other. So that was our double bubble sign, and that made the diagnosis of the duodenal atresia. So the first thing that comes to the patient and the first question that comes to the mind, that why it was not detected in our mid-trimester anomaly scan. When the patient goes and get their mid-trimester anomaly scan, they believe that each of the anomalies of the baby will be diagnosed by the doctor. So what the literature says. So our Bible, that is our Dario Palladini book about the congenital fetal anomalies, says that diagnosis based upon the recognition of the classic double bubble associated with the polyhydramnios, which often develops in the late second and early third trimester. So you cannot diagnose double bubble sign and duodenal atresia before that. And usually when the mid-trimester anomaly scan is carried out, that is 19 to 20 weeks of gestation in most of the countries worldwide, polyhydramnios is absent and the double bubble has not completely formed. So basically there are a group of anomalies that will be detected later on and not early. So what the literature says. So this paper published in White Journal in 2020 that concluded that a high proportion of the fetal abnormalities are detected for the first time during a routine ultrasound examination at 35 to 37 weeks of gestation. So you can detect an anomalies as late as 35 to 37 weeks of gestation, and such diagnosis and subsequent management, including selection of timing and place for the delivery and postnatal investigation, could potentially improve the postnatal outcome. So you have to counsel the patient, show them the silver lining that, okay, we have diagnosed this and this will be prompt us for the management. So this was very crucial that we have diagnosed this anomaly even it's so late, because they actually appear so late. So these are kind of literature always help in the counseling of these patients. So what should be looked in the third trimester ultrasound, and to what extent we can look for the anomalies in this scan. So basically routinely we see the fetal presentation, the placenta, biometry and the fetal growth pattern, amount of the amniotic fluid, heart rate and rhythm, maternal part length of the cervix myometrium and multivessel Doppler. But we should also attempt to look for the fetal anatomy as much as possible, though we are restricted by the advanced fetal age as well as by the reduced amniotic fluid most of the time. But whenever we have a limitation, we should also write it down in our report, and that will save our skin in those cases. So what are the common anomalies those are detected in the late second and the third trimester? So most common abnormality first seen between 35 to 36 weeks or 37 weeks is a hydronephrosis, ventricular septal defect, mild ventriculomegaly, duplex kidney, ovarian cyst, and arachnoid cyst. Ovarian cyst, we are sorry, cyst actually is a post natal diagnosis. So basically, we see a cyst in the fetus, and that was later diagnosed as an ovarian cyst. But there are a group of anomalies; those are exclusively detected at 35 to 37 weeks, and those are ovarian cyst, micro cephaly, achondroplasia, dacrocystocele, and the hematocorpus. Those are exclusively detected between 35 to 37 weeks of the pregnancy. And one of the most important cause of the medico-legal issue is the skeletal dysplasia, that is most commonly detected between late second trimester and the third trimester. Because if you see here that this was detected at 31 weeks, 3 days, where all the long bones are below the 5th centile. So we should always keep in the mind during our counseling that skeletal dysplasia almost always detected in the late second or the third trimester. Amniotic band syndrome is one of the major cause of the medical legal litigations. Reason being that in amniotic band syndrome, there is an early rupture of membrane and the fibrous band adhere and entrap the fetus, as you are seeing on the left side of your screen. And this causes limb amputations and deformities. So the many times these amniotic bands are visible. Many times they are so microscopic. They are not visible during the ultrasound, but they may cause the auto amputation of the limb. This can also causes in a cephalocele and facial cleft, ventral wall defect, as well as ectopia cordis. Limb reduction defects is one of the most common causes of the medical legal issues, because most of the time the patient says that during your anomaly scan you have shown both the legs, but when the fetus was delivered, why one leg was having issues. So basically they are described defect in the literature, and knowing about them always save your skin. This is one case that we have lately seen, and if you see that both the femurs were not developed. You see that this is one lower limb, and it was another lower limb. So both the lower limbs were not developed, and we also saw that there is a small thorax that is a sign of the skeletal dysplasia. And when we further investigated this case, so we find that there is spinal dysraphism also, plus the increased nuchal fold thickness. So this was a combination of skeletal dysplasia as well as amniotic band syndrome, and both are having a late presentation. Polydactyly is another medical legal issues, in which you will see an extra finger here, and many times that is syndromic. Like in this case, we saw that there is a polydactyly, as well as we saw there is an cephalocele that is a part of the Mickle-Gruber syndrome. So it can be post-axial, that is the 6th digit, maybe on the other or fibular side, that is much more common than the pre-axial, where the additional digit is located on the radial or the tibial side. So why few of the anomalies are detected in the late second and the third trimester? So the first thing is there is an incidental or accidental detection that can happen because the patient was sent for the growth scan or the obstetrical Doppler, but we should made an attempt and we saw it. And there was a second opportunity also for the missed abnormality, so we should always look for it. But there are anatomical structures, those are evolving. anatomy is not fixed in the fetus. So they keep on evolving. Like there might be one ventricular septal defect that we see 5 mm in the third trimester. So it will be perhaps that small that is not been detectable by the naked eye during the 18 to 20 weeks scan. Plus, there is the progression of a suspected anomalies. There are sometimes that regression of an abnormality is also been done. You who detect a suspected a clubfoot, and that clubfoot is not seen in the third trimester. There are late infection, insult, and hemorrhages also. There are few fetal infection that actually present with the fetal abnormalities later on, like the ventriculomegaly. And there are mal rotations also, particularly the gut during the embryological development. So these are the causes why the few of the anomalies are detected in the late second and the third trimester. But what are the common anomalies? Those are detected postnatally, that is after the birth. There are isolated cleft palate. Even the best of the centers of the world find it difficult to diagnose the isolated cleft palate prenatally. Most of the time, we diagnose cleft palate when they are associated with the cleft lip as such. Polydactyly, I have just discussed, syndactyly also, and the ambiguous genitalia, that is the hypoaspadias. But in India, we actually write it down that we have neither detected nor disclosed the sex of the fetus. So onus doesn't lies upon us for the sexual organs. But what the guideline says about the mid-late trimester anomalies. So guidelines clearly say that we should follow not in our counseling verbally. We should also take a written consent from the patient before every anomaly scan. That is, before starting the examination, a healthcare practitioner should counsel the woman or couple regarding the potential benefits and limitation of a routine mid-late trimester fetal ultrasound scan. Although many fetal malformation or anomalies can be identified at the mid-trimester scan, some may be missed or may become apparent only later in the pregnancy, even with the best sonographic equipment in the best of the hand. So that is our guideline 2022 by the ISWA, that is the international guideline. And what our national guideline by our own, the Society of Fetal Medicine. It is health care, the provider and patient must be aware that some anomalies may be missed even with the best ultrasound equipment in the best hand. From a legal point of view also, a healthcare practitioner should counsel the pregnant female and companion regarding the benefits and limitation of a second trimester fetal ultrasound scan, and a disclaimer should be signed prior to the study. So we strongly advise to get a signed disclaimer before every fetal anomaly scan. And it is also important to be aware that several anomalies may develop later in the pregnancy. So why this kind of limitation happened with the second trimester anomalies? Because there are some of the defects, those are developed later in the gestation age. So early or late gestation age, fetal position. If the fetus is persistently prone, so you can't see the face and the heart very well. Multiple gestation that I have discussed in the beginning of this presentation. Oligohydramnios, because ultrasound waves needs window to make the images. So if there is an oligohydramnios, we cannot detect many of the defects. Maternal habitus, that is morbid obesity, that is very common nowadays in our population. So this is also one of the commonest cause, and you should mention in your report always. Fibroids, if there is an anterior fibroid, they again cause poor windowing, resulting in the suboptimal scan and poor window due to any other cause. So what we do, we actually sometimes move the transducer, have patients, we see the patient multiple times, resulting in the complaints to you people कि सर के यहाँ गए और बहुत time लग गया. Reassess on the lateral visit. Many times we call the patient again at from the 22 to 24 weeks, because by 24 weeks the things are become larger. Recognize limitation, we tell the patient, and few of the cases we send the patient for the fetal MRI also. So now few of the most common medical legal issues. Cardiac defect is the second most common defects in the world after liver defect. And it is one of the common causes for the medico-legal litigations. So because there is a high incidence of the cardiac defect and they are associated with the non-cardiac and the chromosomal anomalies, and there is an increased neonatal and childhood morbidity and mortality. And we can also make the defect by making the detection prenatally by the planning the surgical repair and the shorter ICU stay, decision of the delivery road, refer to the tertiary center, and requirement of the urgent postnatal intervention. But there are some evolving anomalies like the hypoplastic left heart syndrome and the aortic valve stenosis. Those cannot be diagnosed in your mid-dead trimester anomaly scan, and they may be diagnosed later on if possible. Rhabdomyomas are known to present at 28 weeks rather than in the 18 to 20 weeks scan. But the good thing is that they also regress afterwards. But rhabdomyoma is known to present after 28 weeks only. So that is one of the cause of the medical case. I have put this case especially for this meeting. Reason being that total anomalous pulmonary venous connections, where there is an abnormal pulmonary venous drainage to the left atrium. So this is in whole of the world, in the best of the centers, the detection rate is 11 to 12%. So, and this is a lethal anomalies. So you just think of that what kind of limitations we have. So what the guideline says, the latest guideline published in 2023 by the ISWOG about the fetal cardiac screening says that however prenatal detection rate vary widely in different geographical regions for various type of congenital heart defect, with fewer than only half of the cardiac anomalies being identified. So it is just the 50% of the cardiac defect that can be diagnosed prenatally, and this is a worldwide data. This is not our data. Some variation can be attributed to difference in the examiner ability, of course, to analyze frequency, patient body habitus, abdominal scar, gestation age, amniotic fluid volume, and patient position as well. But despite that, the majority of the cardiac defects are difficult to diagnose prenatally, though we do our best of the efforts. Down syndrome must be included in this talk. Reason being that when the Down syndrome happens, patient blame everybody. मैडम के पास पूरे 9 months तक ट्रीटमेंट हुआ, फिर भी क्यों हुआ? इसका अल्ट्रासाउंड भी हुआ, सारा टेस्ट भी हुआ. Reason being that 4% of the Down's baby having all the normal ultrasound and screening tests, and that is the worldwide data. So why trisomy 21 important? Because this is common, 1:500 at 20 weeks of gestation, 1:900 in population. They have longevity. Oh, every day they will see the baby and will curse you. They will put this baby before the court and say that this baby will live till 30-35 years of age. How can we support it? And court will be kind enough to grant a huge compensation. And the thing is that they have subtle ultrasound findings than the trisomy 18 and 13. So it is difficult to diagnose. So where the ultrasound stands in the trisomy 21, and just make it clear for the rest of the life. So our Bible for the fetal anomalies, Dario Paradini says that from postnatal and prenatal data, it is evident that about 50% of the individuals with Down syndrome do not show any major or minor anomalies possibly detected in it. So 50% of the trisomy 21 baby doesn't show any signs on the ultrasound. And that detection rate can be achieved by the flipping of the coin itself. So this is the reason ultrasound is not the best of the screening tool for the trisomy 21. If we see the other tools of the screening method, so even our best test, that is combined test, that means maternal age, knuckle translucency, a double marker with nasal bone, ductus venosus, and tricuspid degradation, they still have 93 to 96% of detection. This was the reason I told that 1 out of the 4 4% of the 4 out of the 100 Down syndrome baby has a normal screening test and the ultrasound. Where our NIPT stand. If you see the NIPT report, they say that there is a low risk, but they doesn't say that there is a no risk. NIPT is again a screening test, and there are chances of false positive. False positive can be detected because we will go for amniocentesis and we will diagnose it. But what to do with the false negative? False negative also happened in this country. Recently, one of the obstetrician of Noida Extension faced a lot of troubles because she had advised NIPT and the baby born as a Down's baby. And so this was the reason that there is a pre-test and post-test counseling is mandatory. So the golden rule is that if a fetal structure anomalies or increased NT or nuchal fold thickness is detected on ultrasound examination, diagnostic testing, that is CVS or amniocentesis, should be offered rather than an NIPT, and this is the golden rule. Management decision, including termination of the pregnancy, should not be based on the result of the NIPT. Women whose results are not reported indeterminate or uninterpretable, that is no call test, cell-free DNA should receive further genetic counseling and be offered comprehensive ultrasound evaluation and diagnostic testing because there is risk of aneuploidy. So whenever your lab says that ma'am इसकी report में बहुत time लग रहा है, इसका fetal fraction कम है, just this is a red flag sign because these cases are indeterminate and they have an increased risk of aneuploidy. Women with positive NIPT should be offered amniocentesis rather than a CVS because amniocentesis is a direct testing of the fetus because in the amniocentesis we take the amniotic fluid that is produced by the baby exclusively. So these are the golden rules of NIPT. And this was the interesting case where NIPT shows the increased risk for trisomy 21, and we went for the amniocentesis. I did it on 20th of June last year, and on the QFPCR, nothing was detected. It was perfectly normal. So we thought that there is a false positive. But we in our institute there is a mandatory karyotyping as well. So we did the karyotype also. And what we find that there is a mosaic trisomy 21. So this would have been missed if we would not have added karyotype to it. So the interpretation of this karyotype was that 40% were cell with the presence of an additional copy of trisomy 21, suggestive of trisomy 21 mosaic, and the 60% were the normal complement. So finally, we have diagnosed the trisomy 21 because we have added karyotyping. So where we stand in the world. So as Sharda ma'am has just discussed, so we are preparing our own position, a statement after continuous pushing from Sharda ma'am since very long, and we have researched a lot. So if you see, we have researched for the pediatric journal, we have researched to the Swedish journal, we have researched also in the NHS. We didn't stop there, and we went and searched for the Egyptian journal as well as in the German journal. And what we find? We find that this was the detection rate. So still you see the serious cardiac anomalies, it has a detection rate of only 50%. Lethal skeletal dysphagia has a detection of 60%. Diaphragmatic hernia rate has detection of 60%. And what the world guidelines say, you will just laugh at it. So in the world, these statements are that several organizations have attempted to make the purpose of the scan more focused by identifying the main structure to be assessed, and this key structure has been described because there are major malformations which are either fatal or cause significant morbidity and has a detection rate of just more than 50%. And it is understood that there are other conditions that may be detected using this ultrasound screening tool, but because there are insufficient data to accurately predict the standard to which it can be achieved. A systematic review investigating the use of ultrasonography for the antenatal diagnosis of structural congenital anomalies In low income and middle income country reported median detection rate was only 16.7% in Africa. In South America, it was 34.3%. In Asia, it was 34.7%. And in the Europe that we all idolize, it was 47.3% only. So while another study on sensitivity of the routine ultrasound examination for the detection of the abnormal chromosome and structural malformation in fetuses in second trimester in non-selected population of Sweden. Sweden is a country where everything is controlled by the government. Report a sensitivity for the prenatal detection before 22 weeks to the 40.3%, that is less than 50%. And the prenatal detection rate of the chromosome anomaly was 60.7%, and for the structural malformation was only 39.0%. So this was the world best healthcare system, where there is no load of the patient as we did in our day-to-day practice. So they concluded that in a routine clinical setting at a country hospital with a non-selected population, half of the major structural malformation in chromosomally normal fetuses are detected. Only half. So whole of the world agrees that only 50% of the major malformation can be detected by the routine ultrasound examination in the second trimester. So this was the world. So what to do when this thing happens? So counsel the patient that there should be no blame attitude. Second is there is no loose talk. You should go by the guideline, show them that what the other people's detection rate are in different countries. Counsel with compassion. You should always be on the patient side and you should be the part of their agony. Give adequate time. It should not be a hush counseling where patient feels that doctor is not interested in sharing their sorrow. And discuss detection rate worldwide. What the worldwide detection rate of that particular anomaly. Show them positive side, that is rehabilitation, correction, or surgery. Discuss and involve with ultrasonologists, fetal medicine specialists, geneticists, pediatric surgeon, and cardiologist if needed. So that's what I have to say all about this medical aspect of the congenital anomalies. Thank you so much for making part of this meeting. Thanks for all your efforts.